I put diflunisal in. Do people remember diflunisal? It's not available anymore, but I thought I'd leave it in just as it's a non-steroidal anti-inflammatory. But we actually used to use it in a very small group of patients because it was one of the drugs that NSAIDs that didn't actually affect the platelets, unless you used a very high dose of it. But of course, for drugs that have a very small, margin for actually using them, if they're not prescribed, they disappear, and diflunisal is no longer available. But we used to find it useful from time to time when we'd have those patients with bleeding problems or had thrombocytopenia and had bleeding potential to give this drug. So it's unfortunate that it's passed on, so to speak. So the other non-steroidal anti-inflammatories, so they're considered to be useful for the relief of metastatic bone pain and soft tissue pain. They've been available for many, many years. They can cause changes in bowel function, including constipation and diarrhea. They have a more reversible effect on platelet function than aspirin does. And there's groups of drugs. And I think the important thing here is that if you're prescribing these drugs, and once again I'll talk a little bit more about the data in terms of what data there is out there in using the drugs. But just remember, if you've got a patient on a drug, say you had them on brufen or naproxen, and they weren't getting any relief from it, then you might think about changing to another group. Now, I personally wouldn't use... Who still uses indomethacin sort of routinely for arthritis or something? Yeah, but maybe not... Yeah, gout's a... What about just arthritis? Do you use it for arthritis, Indocid? See, yeah, suppositories, yeah. The point that I'd like to make here is basically if you've got someone on one of these drugs and you want to change, maybe it would be a good idea to change to a different group. So you might put someone on some Voltaren, say. If they'd been on naproxen, you might change to something different. So and there's a whole range, isn't there? What else have we got over the page? No. So I don't have any experience with phenylbutazone. That's an old... Is phenylbutazone still available? That's an old-fashioned... That was, phenylbutazone did nasty things to your bone marrow, as I recall. But once again, it's a different group. The oxycams and mefenamic acid, once again, most of these drugs I don't use. I tend to stick to probably brufen, because it's short-acting, it's got a good safety profile, and a lot of patients seem to get reasonably good relief with ibuprofen. And then my next choice would probably be naproxen, and then probably Voltaren. But just remember, if you're struggling with one and you're not getting some benefit, and you think, you're confident, this is a bone pain or a soft tissue pain, then sometimes by switching the drug, as we switch opioid drugs, you can just get good relief. It's and I think back to when I was doing a bit of general medicine. I used to do an outpatient clinic when I worked with the university, and I got referred this lady, and she had some sort of probably seronegative rheumatoid, and going through the things, I started on aspirin, fairly high dose aspirin therapy, didn't work, started on an NSAID the next time I saw her, didn't get much relief, changed next time I saw her, then I gave up. I thought, this lady's not getting any benefit. Referred her to a rheumatologist who tried a different NSAID. Oh, what a miracle worker, He didn't do anything magical, he just used a different NSAID. So it's just good to remember that sometimes if you're not, if the drug's not achieving the desired result, i.e. pain relief, or in this case reducing inflammation, and you're given a reasonable trial, then swap it to something else. So as we sort of already mentioned, so at a clinical level, start with a safe, well-tolerated drug. If it doesn't work, then look at using perhaps a stronger drug, and by stronger I mean usually a drug with worse side effects, really, or potentially worse side effects. It theoretically can be used in conjunction with paracetamol, but I remember talking to one of the doctors who was one of the co-authors of the Oxford textbook of palliative medicine. He was horrified by that you might actually mix those drugs together. You either use one or the other. Well, he thought that they did basically the same thing. His feeling was that they were working with reducing cyclooxygen. I disagree. I think they work quite differently. I think they're different drugs. But once again, there's never been any studies on using combinations, comparing, say, an anti-inflammatory. Think about I haven't even talked about the COX-2 inhibitors. Once again, because there is no data on you think there's little data on the NSAIDs, there's virtually no data on the COX-2 inhibitors in treating cancer-related pain. And so, there is no data comparing paracetamol in combination with anti-inflammatory drugs. Okay, so we've talked about suppository forms of the drug, need to be aware of interactions. So, when we have a patient in the unit, say, who's on warfarin because they've had, a clot or whatever, then, you feel very uneasy using an NSAID. But there are other drugs that, you need to be aware of that you can have problems. And of course, these days you can just flick it up on your computer and find out what drugs are going to interact with other drugs. Just something about novel routes. One of the problems with some of the oncology patients, particularly when they're on therapy, or the hematology patients, is they can get problems with mucositis. Diflam is an anti-inflammatory that's got some anesthetic properties, so it's a reasonable thing to use for patients who've got mucositis. And it's also been shown to help with decubitus ulcers, which is interesting. But it is an anti-inflammatory. In terms of side effects, so if a patient is hypersensitive to aspirin, you'd probably be a little bit wary about using an anti-inflammatory, an NSAID. Hematological effects we've spoken about, gastrointestinal injury, and the evidence is that proton pump inhibitors and misoprostol are the drugs to use. And these days we don't use misoprostol, we use whatever, Nexium, whatever. H2 blockers generally do not protect against gastric ulceration. So, the older drugs, Zantac and Tagamet. Who prescribes Tagamet these days? People can buy it over the counter, can't they? Has it? Well, there. Is that right? Tagamet's gone. Well, there you go. But Zantac you can buy over the counter now too, of course, can't you? So drugs that we've seen sort of come and go. Hepatotoxicity. So once again, if someone's got significant liver impairment, you'd be cautious in using it, and of course they can cause hepatotoxicity. Nephropathy, so acute or acute on chronic renal failure, and there's been deaths from using the drugs. Particularly, that's why ketorolac got sort of dropped from palliative care, I think, a long time ago. I mean, it's still used now, and we use it, but it was the flavour of the month drug. Everyone was, on ketorolac. There were ketorolac infusions. Do you use infusions out there or just single doses? Yeah, we used to use infusions of it. So they can get nephritis, hyperkalemia, hyponatremia. Yeah, so people can die from it. One certainly needs extra care if you're hypovolemic in terms of renal impairment. So you can get reactions to these drugs. So once again, if the parent drug, aspirin, causes problems. Photosensitivity, and I must say I don't think I can ever recall seeing anyone who's had photosensitivity. It's obviously fairly rare with most of the drugs that we use. Other skin reactions, so erythema multiforme, CNS side effects, and I can vouch for those with indomethacin. Cardiovascular side effects are usually secondary to accumulating fluid and causing problems with cardiac failure. So the COX-2 inhibitors, so they're the new drugs of the past decade, and they've sort of had their problems as well, haven't they? Who prescribes Vioxx anymore? So on theoretical grounds, they should be effective in treating pain, and certainly studies in rheumatoid and OA have shown that they are effective drugs, but have a better side effect profile. And the bottom line sort of says it all. There's no, whether they work or they don't work in cancer-related pain is up to the imagination. Are those studies going to be done? No, they're not going to be done. It's not worthwhile. Okay, so are there any sort of questions about the simple analgesics that we use? Any experiences that people have had, or problems or issues? with using them. I guess my feeling is that, you think back to the analgesic ladder that we've all seen ad nauseum, and, we're told, you should start off with the simple drugs and that before you go on to strong opioids. My feeling these days is, unless there is, unless you're convinced that there is, bony disease or soft tissue disease where these drugs may have a reasonable role to play. If someone's got advanced disease, you may think about sort of stopping or ceasing these drugs. One of the issues is with paracetamol, as I've already alluded to, is about the number of tablets that they usually have to take a day.